Many thanks for the urology trainees all over the world joining us in this YouTube channel to discuss various scenarios for urology exit exam. Today, as a continuation, we are discussing the rare scenarios possible in the urology exams. Based upon your country, the scenarios what we discuss could be rare or could be quite usual. But from United Kingdom point of view, these are relatively rare. So we just want to cover them also in the next 40 to 60 minutes. Okay, we are starting with the first scenario.
Yes, please.
Thanks for allowing us to record. It will be very handy for your own future revision and also for the other trainees who are not online today. You had a patient referred from gynecology department. The predominant symptom is she is leaking urine through vagina. How are you going to evaluate her?
Okay, and is the patient having any recent surgery?
Yes, she had history of total abdominal hysterectomy with bilateral oophorectomy for cervical cancer 6 weeks back, and the leak per vagina started 2 weeks after the surgery.
Okay, so I will, the patient, I assume that the patient is coming to the clinic. So I'll review the patient in the clinic. I will take a brief history, do examination in the presence of chaperone, and arrange some investigation. My concern is a possibility of a vaginal fistula or ureterovaginal fistula following her surgery for cancer. So I'll take a history from the patient, asking about her baseline urological history. Is there any difficulty in passing urine previously? Any form of incontinence before the surgery? Whether the patient had before any previous surgery or radiotherapy? About her medical background, the use of any medication? About smoking, drinking habit, and also about her social life. And then after, I will take the history from the surgery onward, when the leak was started, what is the severity of the leak, how many pads she used daily. Apart from the leak, is she having incontinence with the leak as well, any visible hematuria, any urinary tract infection, the impact of this leak on her social and sexual life. And then I will proceed to examination of the patient in the presence of chaperone with the patient consent, starting by general examination, then abdominal examination, looking for any palpable mass or tenderness in the loin, any palpable mass or tenderness in the suprapubic area. Then I will examine the perineum in the supine and the left lateral position, looking for any obvious abnormality like uterine diverticulum, prolapse, cystocele, rectocele. I will ask a patient to cough to see whether there is any leak. I will see if there is any visible spontaneous leak of fluid or pooling of the fluid in the vagina. And then I will examine the patient with the help of Simpson's speculum for further inspection. And after that, I will try to check the operative note for the patient to see if there is any difficulty during the surgery. At that time, any recognized injury during the procedure, what was the histology, the MDT decision, whether the patient is waiting to have a further treatment in form of radiotherapy or not. I will ask the patient also to provide a urine sample for urine dipstick, and I will send for cultural sensitivity if there is a suspicion of infection. I will arrange for a baseline full blood count, kidney function. I will send some of this fluid if the patient able to collect it. I will send the sample for estimation of creatinine in the fluid and compare it with the serum creatinine and take it from there.
Good. Again, very extensive, nice, comprehensive answer. I'm going to raise a concern, but unfortunately, I don't have a proper answer or solution to that. In the exams, just look into the examiner's face and see how happy they are. If they feel bit apprehensive on you having such a big opening gambit, try to cut short without losing the main things like looking into operative notes, arranging upper track investigations, and as you said, comparing the urine from the vagina and the serum creatinine. So just make the main points, because sometimes you will lose the precious time. You can't discuss the scenario completely in 10 minutes. But on a good day, this is absolutely fine. But just keep that in the background, that a good opening gambit will give you a big 6. From the 6, you need to progress to 8. That's the main idea of the exam. Okay?
Yes.
Very good. So just to answer some of your questions, she had quite a difficult surgery because of the nature of the cancer in the cervix. No signs of any involvement of ureter during the surgery. The surgeon haven't had any clue that there is a possibility of injury to the bladder or ureter. And she's got continuous urine leak, and the urine sample drained from the vagina did confirmed to be of urine as per the investigations, as you said, in comparison with the serum parameters. And she had past history of 3 normal deliveries. She's not medically having any diseases. Otherwise, rest of the investigations were pretty normal. She's quite healthy. She's quite annoyed by this nuisance of urine leak, which made her to wear incontinence pads continuously. How are you going to take this further?
So after that, I want to arrange for imaging to see the source of the fistula with the urinary tract. So I will arrange for the patient to have a CT urogram with a delay phase and a CT cystoscopy as well, to see the site of the fistula and the location and other factors.
Okay. Her CT urogram showed bilateral normal draining kidneys with no evidence of any hydrouteronephrosis. The contrast reaching the bladder comfortably. Unfortunately, there is a vesico-vaginal fistula resulting in the contrast leaking into the vagina. No signs of any abnormalities noted in the bladder. Rest of the abdominal contents, including intestines, were normal.
Okay. So in this case, since the clinical investigation supporting the possibility of vesicovaginal fistula, then I will have a chat with the patient about the best way to repair this. Since the patient is with me in the clinic, I will arrange to have a flexible cystoscopy, which will give me an idea whether the fistula will be visible, the size of the fistula, the location in the bladder, which may be helpful in planning the treatment. I will explain to the patient, since she had a relatively recent cancer surgery, it's not advisable to do a repair in short time. So I will allow the time for everything to settle. I explained to the patient that I totally understand it is quite inconvenient to have this leak for further a few weeks. I will support the patient with some continence appliance. I will involve a continence nurse in the discussion. She will give her written information and contact details if she needs any further support. And my plan is to arrange for the patient to have a repair of the fistula in about 3 months from the initial surgery.
Okay, your flexible cystoscopy shows that her fistula is just above the interureteric bridge, just above the trigone. Rest of the bladder wall seems to be normal. There is no signs of any suspicious lesion, good bladder capacity. And the fistula is a definite finding, no evidence of any suspicious around the fistula. Just by visual appearance, it appears like 5 to 10 millimeters, and it is corresponding to a small dimple in the anterior wall of the vagina also during the flexible cystoscopy. And why do you want to wait any further? She is now 6 weeks from post-op. She's quite tormented by this urine leak.
The idea is that if we do the surgery early, the tissue in this area will be cemented, and vascularity of the tissue is not optimal. So the rate of success of the fistula may be lower. So I would prefer to allow at least 10 to 12 weeks after the initial surgery, and then we can do the fistulectomy.
Okay. So is there any role for early repair? Say, for example, if the patient presented within such a date, you will do early repair. Is there any role?
If the injury or the fistula was diagnosed very early, usually within 1 week to 10 days following the injury, then there may be a rule for early repair. But if it is after two weeks, it's better to give a time for the tissue to heal completely and then consider repair.
Good. So it's mainly like we don't want the chronic inflammation to set in. It's nice to operate in the early setting, maybe in the presence of acute inflammation. But after 10 days, once the chronic inflammation sets in, you need to really wait for the tissues to regain its strength. And so what is the actual duration you wish to wait from the date of surgery?
It's something between 10 to 12 weeks.
Okay, some people even go for a complete 3 months, as you said, 12 weeks. But 10 to 12 weeks means it's, 2.5 months, 3 months is good. You can say 3 months in the exam, which is much more standard. Okay, so what are you going to do? You are supporting her with a continence service and then you are seeing her in 3 months' time. What's your plan?
So my plan is to arrange for the patient to have a transvaginal repair of the fistula. I am aware of that. We have mainly two approach to repair the fistula, either transabdominal or transvaginal. Both of them, they have the same success rate. However, the rate of complication is more with the transabdominal. The length of stay in hospital, need for catheter are more. All of them are more with the transabdominal. Therefore, my plan is to arrange for a transvaginal repair with possible use of Marcius fat pad graft.
What other conditions will help you to choose either transabdominal or transvaginal approach? Is the location of fistula makes any impact on that?
Yes, the factors include the location of the fistula, the size of the fistula, the experience of the surgeon, the presence of any associated abnormality like in the vagina or in the abdomen, all will help to decide.
Okay, take me through the happenings on the surgery date.
So the patient will be admitted on the day of the surgery. She will be anesthetized, prepped, WHO checklist, prophylactic antibiotic. And then after that, we will do a cystoscopy, identify the site of the fistula, and try to put a stent through the fistula. And then after that, transvaginally identify the site of the fistula in the vagina as well. Excision of the fistular tract, which will be sent for histology to exclude any cancer. And then after that, we will do a multi-layer repair of the bladder, separate from the vagina. Should be tension-free, watertight, multi-layer repair. I will try to avoid any overlapping of the suture line. I will try to keep a tissue interposition in between the vagina and the bladder. Therefore, I would use the Marcius fat pad. And then I will keep a catheter in the bladder for at least 2 weeks, and then I remove it after a cystogram confirming no leak. I will keep the patient on a prophylactic antibiotic. I will advise the patient to avoid any sexual intercourse for at least 6 weeks following that.
Okay, take me through the Marcius flap. What is the types or blood supply and how are you going to harvest it?
So usually it is the Marcius, it's taken from the labia. It is an elliptical flap of a skin with the underlying fat pad. If it is taken from the upper part of the labia, then it will be relying on the external pudendal nerve. If it is taken from the lower part, will be relying on the internal pudendal artery. If it is taken from the upper part, external pudendal artery. From the lower part, internal pudendal artery. I will take this flap and then rotate it to suture it in between the bladder and the vagina to reduce the chance of recurrence of the fistula. And I will inform the patient about the possibility of paresthesia and diminished sensation in the area of the graft.
Okay. Take me through the suture material which you're going to use and what type of catheter you're going to place.
So I will use a non-absorbable suture. So for the closure of the bladder, I will use a 2O vicryl, 2-layer repair. And for the vagina, I will use the same suture, and I will leave a 14 French urethral catheter at the end.
Okay. What is the difference if you are approaching this fistula transabdominally?
The main difference is that I will use the omentum for interposition between the vagina and the bladder.
Okay. Happy to have another scenario?
Yes, please. Yeah.
Okay. You have a patient referred by the gynecologist for right-sided hydrouteronephrosis. The patient had right-sided large ovarian cyst removal. Post-operatively, she was well for almost 6 weeks, but then developed a nagging right side loin pain, for which they did ultrasound which showed right side hydrouteronephrosis. The surgeon felt that it could be related to the right side oophorectomy surgery. How are you going to evaluate her?
So I'll see this patient in my clinic. I will take a brief history examination in the presence of chaperone with the patient's consent and arrange for investigation. I will review the operative note prior to reviewing the patient. I will check the histology from the ovarian cyst, and I will see the plan if there any further treatment needed from the gynecology side. I will take a patient history about any pain at the moment, any history of fever, rigor, feeling unwell, any visible hematuria, any urinary incontinence or leak, about her past medical and surgical history, previous gynecological history, drug allergies. And then I'll examine the patient in the presence of chaperone with the patient consent, looking for any palpable muscle tenderness in the loin, any palpable bladder, inspect the genitalia and examination with the Simpson's speculum. And after that, I will do urine tests for urine dipstick. I will arrange for a baseline full blood count and renal function. And I will arrange for the patient to have a contrasted CT urinary tract, since my concern is a possible ligation of the right ureter during the cystectomy procedure.
Okay. Her investigations were normal, no signs of any inflammatory markers increase. Her CT urogram did show right side hydrouteronephrosis, and there is a sharp cutoff at the level of the just distal to crossing vessels. Left kidney seems to be functioning well without any blockade, contrast reaching bladder adequately. What are you going to do?
So for this patient, my preferred approach is to do the minimally invasive via cystoscopy, retrograde study, and possible insertion of a stent if it is possible. So I will consent the patient for a GI procedure involving cystoscopy, retrograde study, and then I will try to pass a guide wire followed by catheter insertion to increase the chance of success of my procedure. I will arrange with one of my interventional radiologist colleague to be available in case we can't approach it from down below. Then he will be ready. He can do nephrostomy, percutaneous nephrostomy, and then possibly try to insert an antigrade stent. It's like a rendezvous procedure, which may help to bypass the stricture if it's possible.
Okay, how will you do this rendezvous procedure?
So it will be done by a surgeon from down below and an interventional radiologist from the kidney. I will start by doing cystoscopy, retrograde study to identify the distal segment of the ureter. At the same time, the radiologist will put a nephrostomy, which should be straightforward since the system is dilated. He will put some contrast so we can see the cutoff of the upper segment of the ureter, and then we can determine the length of the injured segment of the ureter. I will try to pass a guide wire if I can. If not, then he will try to pass a guide wire from upward, and then if he is successful, we can leave an antigrade stent in place.
Okay, if there is no way the guide wire can be passed both retrograde or antigrade, what other choices you have?
So in this case, since it is 6 weeks since the injury, I will just ask the radiologist to keep a nephrostomy in place, which will relieve the obstruction in the kidney and preserve the kidney function. And then I will arrange for the patient to have an open repair at 3 months from the initial surgery.
Okay, just to add there, rendezvous procedure not only stops just with passing the guide wire. In case if the structure is so tight and it is not possible with the guide wire, for example, from below a surgeon can have a semi-rigid ureteroscope, from above a surgeon can have a flexible ureteroscope, and one of them can switch off the light source and they can see the light source from the other partner and try to use a laser to create a channel on the scar, and that can help to pass the guide wire, and then you can do a balloon dilatation in the same sitting. Try to put as much bigger stent as possible. Sometimes we can do more than 4.5 French, which is okay to start with, and then later once things getting epithelialized, we can slowly do a balloon dilatation and do some reconstruction also. Let us assume that your patient, they are not able to see the light across and they are not able to do a kind of a tunneling. As you said, she has a nephrostomy in place. So how are you going to reconstruct her?
So I will consent the patient for an open exploration and repair of the right ureter. And the information that we get from the antigrade and retrograde pyelogram should let us know exactly the site and the length of the defect on the ureter. If it is in the lower ureter and it is less than 2 centimeter, which could be due to just a suture or ligature, then I may be able to just excise this segment and do direct ureterostomy. If the segment is a little bit longer in the lower ureter, then I'll try to do ureteric reimplantation with or without psoas hitch. If the defect is in the middle part of the ureter, then I will try to do again either ureterostomy, transureterostomy, or bavari flap.
Take me through the transureterostomy procedure.
So for transureterostomy, I will try to do a limited dissection of the right ureter with the preservation of vascularity, and then I will try to anastomose the right ureter side to end into the left ureter. We need to exclude the presence of certain disease before the transureterostomy, like the presence of upper tract TCC, stones, a stricture on the left ureter, and any distal obstruction. After that, I will try to do the dissection of the right ureter, preferably retroperitoneal if it is possible. And then I can take it into the left side and do the end-to-side anastomosis. I will put a stent, I will do spatulation, watertight, tension-free anastomosis. I will leave a non-suction drain, and I will leave a urethral catheter in the bladder. Sometime, if the inferior mesenteric artery is in the way, sometime we may need to do an ligation of the inferior mesenteric artery.
Okay. In the exam, you need to add that, say, for example, our scenario has got the injury in the right ureter. You need to mention that I am aware that I am using the normal non-injured left pelvic axial and ureteric system, and it is a normal system. By chance, if there is a problem in the transureterostomy, you may jeopardize the drainage from the left kidney also. So I will run through this significant possibility preoperatively with the patient, because end-to-end ureterostomy, especially if it is a upper ureteric stricture, is a quite an ideal choice. Other options, as you said. Take me through the psoas hitch procedure.
So for the psoas hitch, our aim is to give the bladder extra length to shorten the defect by suturing the bladder into the tendon of psoas minor muscle. So I will do a small longitudinal cystostomy incision, and then I will inspect the bladder from inside, make sure that the bladder has a good capacity, no other pathology inside, and then I will put my fingers and pushing the bladder as much as possible toward the psoas minor tendon on that side. If the mobility of the bladder is limited, then I need to do a ligation of the superior vesical pedicle on the contralateral side, and then after that I will use a PDS 20 PDS for fixation of the bladder into the psoas minor tendon. I will be careful not to injure the genitofemoral nerve, which is close to the psoas minor tendon. And then after that, we can either do a direct, after that, I should be able to do a direct reimplantation of the ureter into the bladder, and the sausage will give a support for the support and stability for the reimplantation. And then I will close the bladder over a catheter.
How will you identify the genitofemoral nerve?
Usually it's visible by inspection. It should be lateral to the psoas minor muscle.
Okay. Take me through the bavari flap procedure.
So for the bavari flap, we should ensure that the patient has a adequate functional bladder capacity, no previous history of bladder surgery or radiotherapy. The most important principle in creating bavari flap is a wide base, and the length to the base should be 4:1 to ensure adequate vascularity. So I will do a U-shape incision with the cautery. I will measure the defect in the ureter, and then I will take a U-shape flap from the dome of the bladder, and then reflect it upward, tubularize it, and then I will do anastomosis of the ureter to the this flap. I will try to do some mucosal tunneling of the ureter in order to reduce the rate of reflux. I will put a stent through the repair. I will leave a catheter and abdominal drain and take it from there.
Okay. And how are you going to follow up this patient? Let us assume your patient required a bavari flap with a stent in place.
So for this patient, I will take the drain first within 2 to 3 days, where if the drain is not draining anything more than 40 ml per day, I will take the drain out first. The patient will be discharged on antibiotic in the presence of urethral catheter and ureteric stent. I'll bring the patient back in 2 weeks for cystogram. And then if there is no leak from the bladder or from the bavari flap, I will take the urethral catheter out. And then I will take the stent in about 6 weeks. This patient will need a long-term follow-up since I'm concerned about the possibility of stricture at the site of the anastomosis. Therefore, I will arrange for the patient to have a follow-up in 3 months' time by having a blood test, check the kidney function. I will arrange for ultrasound to check if there is any hydrouteronephrosis, and I will do also a MAG3 study to check the split renal function and to exclude any obstruction. If there is any concern from the ultrasound or MAG3 about a possible stricture, then I will arrange for a procedure in the form of cystoscopy, retrograde, plus minus ureteroscopy.
Okay. Just when you're saying the catheter, instead of urethral catheter, just spell it as bladder catheter, because you will be saying ureteric on and off. So the examiner should not get confused about ureteric catheter. So instead of urethral catheter, say bladder catheter. Okay?
Yes, thank you.
Okay, good. What kind of complications you may expect in the bavari flap?
So the possible complication related to the bladder or to the flap. To the bladder, there may be reduction in the functional capacity of the bladder, and the patient develops some symptoms of frequency, urgency, and pain. Usually the bladder is a generous organ, and by time there will be dilatation or will be stretching of the bladder, and most of the time the bladder will regain its functional capacity. Regarding the site of anastomosis, there is a possibility of stricture at that site, possibility of reflux.
Okay. Let us go to the next scenario. Are you happy with that?
Yeah. Are we getting like a feedback at the end?
Yes, I'll give you a feedback in the end.
Thank you very much.
No major concerns. If there is anything, I'll get back to you then and
Thank
there. Good. You have a patient post-radical prostatectomy presenting with significant stress urinary incontinence almost from the day he had his radical robotic-assisted prostatectomy. How are you going to evaluate him?
Sorry, how long down the line where I'm seeing the patient after how many months?
Yeah, it's 6 weeks from the surgery.
Oh, so okay. So I review this patient in my clinic. I will check the operative note of the surgery, whether it is done robotically or open, any difficulty encountered during the surgery, whether navel sparing was done or not. I will check the histology regarding the margins, regarding the final histology, MDT outcome to see if the patient is supposed to have further adjuvant therapy, any radiotherapy or not. All this information are important. If there is any PSA done post-operatively to know his baseline PSA. I will ask a patient in the history about his previous urological history. If there is any voiding or storage lots previously, any incontinence, visible hematuria, any history of UTI. His baseline continence status and age is important to expect his outcome following the surgery. I will ask also about his medical history, any history of diabetes, other medication, any previous radiotherapy prior to his surgery, whether he is a smoker, type of fluid and drink that he is taking. I will ask about the current incontinence, how many pads he is using daily, and the impact of that on his social and sexual life. I will ask about his sexual function as well, and whether he is constipated or not. And then I'll proceed to examination the presence of chaperone with the patient consent. I'll examine the patient looking for any palpable bladder. I will examine the genitalia and arrange for the patient to have a urine dipstick, to have a flow rate and the bladder scan. I will give him the IPSS form also to assess his lower urinary tract symptoms and take it from there. Okay. Examination wise, he's quite thin built. There is no concerns from the oncology point of view. The histology showed Gleason score 4+4. Good expected PSA outcome. There is no margin positive in the resected prostate. There is no need for lymph node resection, so patient haven't had any lymph node dissection. Examination wise, digital examination was normal, flat surface, and you did a flexible cystoscopy, urethrocystoscopy, which showed normal urethra and adequate anastomosis. No signs of anything like anastomotic stricture, but the main concern is the patient's incontinence, and otherwise he's quite fit. How are you going to treat him? Yeah, so my main concern are three possibilities for post-prostatectomy incontinence. Sorry. For the post-prostatectomy incontinence, one of them excluded, which is bladder neck contracture or urethral stricture. The other possibility is de novo bladder overactivity or stress incontinence related to sphincter weakness. I want just to mention that one of the things that help to predict the outcome of continence after the surgery is the anatomical functional length of the urethra preoperatively, which may help to predict the outcome. For this patient, usually we start conservatively by explaining that this is one of the known complications of prosthetic surgery, unfortunately. Support the patient psychologically, involve the continence nurse, provide him with a continence supplement. And usually we allow for at least 6 months for conservative treatment. I will make sure that the patient is already doing the pelvic floor exercise, which may help to improve. Sometimes if the patient is not able to do it properly, I will involve the physiotherapist with the possibility of biofeedback or electrical stimulation, which may help to improve the outcome of pelvic floor therapy, which may be helpful on the short term in about 30 to 40% of the patient. I will arrange for the patient to be seen again at 6 months from his surgery.
How the biofeedback works?
So the biofeedback is some of the patients, they are struggling to perform the pelvic floor exercise properly. So we provide the patient with either audio, video, or tactile feedback, so he can identify and appreciate the pelvic floor muscle more, and then he can do the pelvic floor exercise properly.
Okay. Let us assume you are doing everything possible, but patient has no improvement and he is quite diligently following your advice of physiotherapy, etc. And he is just putting up with incontinence pads for months and months. And now the stage of 5 to 6 months has reached. What other options do you have for him?
So usually the natural history of continence following the prostate surgery, that it will improve by time, and to start with about 60 to 70% of the patient, they will have some form of incontinence, but by the end of the first year, only 5 to 10% of the patient will need 0 to 1 pad per day. However, if the patient is having a significant incontinence, try the conservative therapy, and he is quite annoyed by that, then we can consider treatment at 6 months. For this patient, I want to complete his investigation by doing a video urodynamic for further assessment of his bladder and the bladder neck. I will discuss his case in the pelvic MDT, and then I take it from there.
Why do you want to do video urodynamics specifically? What is the input you are expecting?
Because this is a complex form of incontinence following surgery. So I want to see whether there is any bladder overactivity, whether there is a reduced compliance or not. I want to see his voiding, bladder contraction, and to see the bladder neck during voiding, if there is anything related to the decision to do the repair. Also, it is important to have a 24-hour pad weight, which gives us an idea about the severity of incontinence. If it is 0 to 100 grams, this is mild. 100 to 300 gram is moderate, and if it is more than 300 grams, this is a severe incontinence, which is an indication for early repair.
Okay, at one point you can also have a kind of a bladder diary which will tell you about his caffeine intake, water intake, get history about constipation. Use other conservative measures, like for example, if he's a smoker, you need to be quit smoking, and also stopping the effervescent drinks or caffeinated drinks. Okay, all the investigations pointing out that the main problem is with the sphincter. So what is your protocol? How are you going to treat him?
So I will start treatment with conservative measure, especially if the patient is not that fit. I will start with the urethral bulking agent, which may help to give a temporary relief. I inform the patient that this give him a temporary relief. It may need to be repeated. Duloxetine also can be tried, and it may give patient some improvement. However, with such a significant incontinence, I think the patient is heading toward a surgery. If the incontinence is mild to moderate, according to the 24-hour pad weight, then I can offer the patient either a sling or artificial urethral sphincter, according to the master's study, which showed non-inferiority of the sling for the management of mild to moderate stress incontinence post-prostatectomy.
Okay, take me through the bulking agents used in this purpose.
So the bulking agent, mainly we are using polyacromyl hydrogel, which is Bulkamid. It is injected at 3 sites in the urethra. It will cause a cooptation of the urethral mucosa and increase the outlet resistance, which may help to improve continence. However, I inform the patient that this is a permanent substance, but the effect may wear off with time, and he may need to have a repeated injection. The overall success rate is around 50 to 70% with the bulking agent. The other one, which is less used nowadays, is the macroplastic, which is silicone, because it's associated with more migration and extrusion into the bladder.
Okay. Take me through the sling surgeries. What type of slings you are planning to use?
So we have mainly three forms of sling. We have the advance, which is a transobturator sling applied at the bulbar urethra. We have the invance, which is a bone anchoring sling. So the sling will be anchored to the pubic bones by screw. And we have the third form from coloplast called Virtuo, which composed of 4 threads. It is a sling attached to 4 threads. 2 of the threads will be fixed to the upper inner thigh, and 2 of the threads will be fixed to the suprapubic area. And then by stretching of these 4 legs, this will give support to the bulbar urethra. So these are the main types of sling that I am aware of.
Okay. After going through various press publications on these prosthetic slings, patient is not very happy with the option. Is there any other autologous slings you are aware of?
Autologous, I'm aware of the autologous. We can use a sling from the rectus sheath, which in a principle similar to the one used in female for stress urinary incontinence. So we do a sling 2 by 10 centimeter. We take a segment of the rectus sheath, and then we apply it around the urethra, and we suspend it on sutures. This may help to improve his continence as well.
Yeah, you can even use the tensor fascia later. So like women, there is an equal opportunity to use the autologous slings, which at least you need to give it as an option when you are discussing the prosthetic mesh-based slings.
Okay, so I was not aware that we can use it like in female. Good.
Yeah. Because of the present changes in the female approach, it's better to give them as an option. What do these mesh were made of? What type of material? What are the characteristics?
They are mainly made of proline, as far as I know, and it's preferred to be of type 1, which is macroporous polypropylene mesh.
Okay. Patient has quite carefully read through the literature which you have given to him, patient information leaflet, and is quite understanding your words. He wished to go for a surgery which gives ultimate absolute dryness and like a final best care. So what other best care you have for him?
The best option is to use the artificial urinary sphincter, the 3 pieces, which are associated with a success rate of 85 to 90% compared to 75 to 80% with the sling. It's associated with better satisfaction, less complication, and associated with a better satisfaction and less revision rate from the sling. However, it has problem like mechanical problem, infection, erosion, failure to control his continence, the need to be exchanged sometime, and also it may induce de novo bladder overactivity and upper tract dilatation in some patient. So if the patient is happy to go ahead, then I will consent him for the artificial urinary sphincter insertion.
Okay, explain the 3-piece prosthesis. What are all the components?
So the main one uses the AMS 800. It composed of 3 components: a cuff around the bulbar urethra, a control pump in the scrotum, and then a reservoir in the retropubic area. And the cuff usually will work by a fluid in the cuff which is about 60 to 70 ml fluid in the cuff, which is enough to give continence for the patient. So most of the time the cuff will be activated. When the patient wants to pass urine, then he need to squeeze the control pump a few times, and this will release the pressure. Patient will pass urine, and then the cuff will refill spontaneously within 90 to 120 seconds following that. The patient need to be motivated. He need to have a good manual handling to operate the pump, and we need to exclude the presence of any urethral stricture and the presence of any upper tract dilatation or uncontrolled bladder overactivity before the insertion.
Okay, take me through the main steps in the surgical aspects.
So for any prosthesis insertion, we need to take an extra precaution to prevent any infection. So I will check the swab of the patient, MRSA and urine sample before he came to the surgery, optimize any medical condition like diabetes. And then the patient will be admitted on the day of the surgery. I advise the patient not to do any hair removal. Procedure need to be done on a theater with a laminar flow, like the pediatric theater, the orthopedic theater. And then the patient should be the first on the list. I make sure that we have the implant, the correct size available. We will do hair removal by clipping rather than by the razor. I will give the patient a prophylactic dose of antibiotic covering both gram-positive and gram-negative microorganisms. Then we will do a good cleaning of the area with betadine for about 10 to 15 minutes. I will use the double glove technique, non-touch technique. Most of the implant nowadays are impregnated in antibiotic. If not, then I will use an antibiotic solution as well intraoperatively. I try to minimize the number of staff, close the door during the surgery, try to avoid any hematoma as much as possible, try to avoid the use of a drain, and shorten the procedure. After the procedure, I will keep the patient on antibiotic for 24 hours. And usually we review him in 2 weeks' time to make sure that there is no early complication. And then we start recycling and the use of the sphincter in 6 weeks' time.
Okay, so when are you planning to remove the catheter?
So I will keep a catheter temporarily for usually about 5 to 7 days, and then we'll take the catheter out. So I need to keep the catheter until I start the activation of the sphincter, which is about 6 weeks. I'm not sure.
Okay, good. Now this patient now settling very well with the artificial urinary sphincter and is now stable for almost like 2 years. But unfortunately, on one fine night, he presents with emergency room with inability to deflate the sphincter. So what is happening? How can you help him?
Okay, so I see the patient. I will make sure that he is comfortable. I will check his bladder to see if there is any distended bladder, whether he's a retention or not at the moment. I will check his OPS. And my suspicion is that it could be a mechanical failure in the pump, which cause failure to deflate.
Okay, so how are you going to treat him?
So I will try to deactivate the sphincter first by deactivate. Yeah, by I will, but it's because one of the ways is to try to touch the pump many times, and then if the fluid start to deflate, but no, it will not going to work in this patient.
Okay.
I'm not sure.
Okay, so obviously this patient is quite anxious, and he has already tried multiple times trying to deflate the sphincter, as you can expect. So the correct answer would be there is a kind of a small knob in the superior surface of the scrotal component which we use to deflate. If that knob is switched off, the sphincter will go to a permanent deflated state. Then patient can pass urine on himself, or the best way is you can pass a 14 French catheter, which will be a good choice. The other thing which you need to bring in is you should strongly advise the patient to tell the doctors that nobody should unnecessarily catheterize him forcefully. Passing a catheter, especially in a non-deflated sphincter, could result in significant erosion, and that particular device will get non-useful, and then you need a revision surgery and things become more complex. So if we are able to deflate it adequately, then possibly the only defect could be that inflation-deflation device, the scrotal component, which can be easily replaced compared to replacing the whole revision surgery of cuff, reservoir, everything. Okay?
Yeah.
Good. This is maybe like one of the emergency presentations which could be asked quite rarely. I'm just trying to pick everything under the sun so that we are not leaving any stone unturned before the exams. Okay?
Yeah, thank you.
Good. Happy to go for one more last scenario?
Yes, please.
Okay. You have a 40-year-old male presented to your erectile dysfunction clinic. He is having this problem of erectile dysfunction for the past 6 months to 1 year. He tried various PDE5 inhibitors in various combinations, and he had initially good improvement, but now the day has come where none of the medications are working, and he wants to explore further surgical options. How are you going to counsel him?
I will see this patient in my clinic. I think that this patient is heading toward a penile implant prosthesis. I will see the patient with his partner, preferably. I will explain about the option of penile prosthesis, that this is the last resort of treatment. It's in some way irreversible because the patient cannot restore the natural erection following the insertion of the prosthesis. I will explain that this instrument is composed of a two-cylinder composed of reservoir and a pump in the scrotum. The insertion can be done under general anesthesia. I will counsel the patient about the side effect, including early side effect like infection, bruises, pain, and late and also the injury during dilatation, include corporal injury or urethral injury, late complication like suboptimal erection, maybe shortening of the length occasionally, dissatisfaction with the result, possibility of mechanical failure, autoinflation, erosion. There is a lack of erection or rigidity in the glands. So if the patient is happy with everything, I will usually prefer to see the patient twice with his partner, make sure that he understands all the information sync well with him, and then I will proceed to the surgery.
Okay, explain the three-part prosthesis.
So the three-part prosthesis, which is commonly used now, composed of a two-cylinder and a reservoir, which is full of fluid. Usually the reservoir will be located in the retropubic area. And there is a pump in the scrotum. So when the patient squeezes the pump, there will be pumping of the fluid from the reservoir into the cylinder, which will give him a good length, rigidity, and girth. And then the patient can have sexual intercourse, and then he deactivated when he finished. So the three pieces prosthesis give the patient a good erection and good flaccidity as well in comparison with the malleable or semi-rigid prosthesis.
Okay, in which way this is different from two-part prosthesis? Is there any advantage in two-part prosthesis?
So the two-part prosthesis, there is no reservoir. It's mainly a pump and a reservoir at the same time, which is in the scrotum, and two-cylinder inside the corpora. The advantage is that mainly in patients who have a previous abdominal or pelvic surgery, and we are concerned about possible bowel injury during the insertion of the reservoir in the retropubic area. So we will avoid this risk with the two pieces prosthesis. And the incidence of mechanical failure and complication a little bit less with the two pieces one.
Okay. Is there any other simple prosthesis available any other options for the patient?
The other option is the semi-rigid or malleable prosthesis, which are easy to insert, associated with less mechanical failure, less infection. But the problem is that the satisfaction with them is quite low, since they don't offer the patient a rigid erection, and they are not completely flaccid when the patient is not using them, and it may be associated with risk of erosion on the long term.
Okay. What are the material made up of these two-part processes or malleable processes? What is the construction of this material?
I think it's mainly composed of silicone. I am aware about the new version of the three pieces prosthesis, that it's made of hydrophilic substance, so it can absorb the antibiotic like gentamicin, and this will reduce the rate of infection. And most of them, they will come impregnated in antibiotic like rifampicin as well, and all this will reduce the rate of infection.
Yes, apart from this, the malleable processes may have sometime metal spring in core, which is the one which helps makes it malleable and maintains the position if the patient needs a sexual intercourse.
Okay.
Okay, a patient presents with a kind of erosion due to the prosthesis. You can take an example like a malleable prosthesis. How are you going to salvage him? Urethral erosion.
Yeah, since there is a urethral erosion, then we are concerned about infection. So we need to remove the prosthesis, the semi-rigid prosthesis, and we need to repair the defect in the urethra, antibiotic cover, allow everything to heal, and then we can arrange for reinsertion of the prosthesis later on.
Okay, very good. I'm quite happy with what we have discussed today. I don't want to stretch further. You need some voice rest also. Any other questions or doubts you have before we conclude today?
No, nothing specifically, just to have a feedback, because I was not 100% sure from all the answer that I give.
No, I mean, your answers are spot on. Only in few places where you have slightly deviated, I tried to jump in then and there rather than leaving it for the last end. There are few things, for example, if you are having a vesicovaginal fistula, the best way to say is I will operate in 3 months time, so that the whole chronic inflammation will settle down, while you said 10 to 12 weeks, which indirectly the same. So these kind of small things, usually the examiners won't bother much. So I will say you are spot on 90% of the time. 10% of the time when you give a kind of a range, your one part of the range is still perfectly in the answer, so it doesn't matter at all. I have no concerns on whatever the feedback I've given then and there. If you have no other questions, I'm very happy with the performance. Just chill out and maintain the same pace.
Good. Thank you very much. Can I ask about one thing? I think one of my friend who had the exam before, he had a history of this case of vesicovaginal fistula in a newly pregnant lady, but the presentation was quite in short time. I think maybe in the first 2 to 3 weeks. The patient was not, I think, was not fit to have the surgery or not keen to have the surgery. So he suggested to put a nephrostomy and a catheter, which is mentioned in one of the lectures that we have in the BAUS course. But the examiner was quite upset with that. And he said how you will think about putting a nephrostomy in a newly delivered lady. So I don't know, because this is one of the options, is conservative treatment of fistula. If it is a small one, then we can put a catheter, bilateral nephrostomy, and keep it for 3 months, which may help to heal the fistula. But is it wise to mention it in the exam or not?
If it is a vesicovaginal fistula, the nephrostomy won't help that much. Say, for example, if there is a ureteric injury, then it's a different ball game. If it is a vesicovaginal fistula, a good 16 French silicone catheter, so that it is not get compressed like any other normal Foley catheter, and it will drain the bladder in a good way, and the nephrostomy will only divert the urine more. If it is a big fistula, Whatever you do, whether you do nephrostomy or whether nephrostomy won't divert, bilateral nephrostomy won't divert bilaterally all the urine away. Definitely patient will still have urine draining into the bladder because peristalsis will be there, and then only you are having the bladder catheter. So the examiner may not be happy because you are placing bilateral nephrostomy, which is quite an uncomfortable procedure for bladder vesicovaginal fistula. And a good bladder catheter is enough to bypass, but in spite of the bladder catheter, she may have some leak. The one thing which is quite clear is primary repair and secondary repair. You can label it like this. Primary repair is the one where on table, if there is a bladder injury, post cesarean or post hysterectomy, you are repairing it. That's one. Or within 1 or 2 weeks, if the patient presents with a problem, you can still repair. Maximum, I will say 3 weeks is the maximum age. If it crosses that, chronic inflammation will set in, and then, as you said, the tissue won't be good enough for the repair to take in. So a patient needs to put up with the incontinence pads at least for 3 months. Then we can do a proper secondary repair with interposition. The one other thing you can say is you can make sure that the suture layer in the bladder and the vagina are not parallel to each other. It could be like a cross. If it's the bladder, if you are bivalving like a vertical incision, in the vagina it could be a horizontal incision. So the place where they cross each other is only at one point, and that point also nicely secured by a omental flap when you're doing transabdominal repair, or a Morse's flap if you're doing a transvaginal repair.
Very good. And is there any factor to decide regarding the site of the fistula, whether it is side abdominal or transvaginal?
Yes, if it is trigonal fistula, if it is a small fistula, if it is just supratrigonal, which you can judge from your flexible cystoscopy, transvaginal is a good choice. The only disadvantage is sometimes transvaginally you are not able to do the Morse's flap in all the ladies. It's not possible. While if it is fistula more towards the dome, if it is a very large fistula, transabdominal is the better choice, which will help you to refashion the vaginal stump if you want, because end of the day vaginal stump is just a stump. And you can also make sure you got a good omentum to be inside, which is much more secure, and a quite large partition between the vagina and the bladder.
Okay. Thank you very much.
So site and size of the fistula both could be taken into context before deciding which one you want.
Yeah, thank you very much.
Good. Any other questions?
No, thank you very much. It was a very good session. Cover a lot of hidden corners.
Yes, and it will be a very good revision source also. You can just hear this again before your exam on one of the day. Do this revision bit early, because closer to the exam I wish you to revise only the common questions. Rare scenarios you should finish by this weekend. No need to touch them in the exam week.
Yeah, thank you very much.
Good. Wishing you a quiet weekend, and if there is a possible time slot, I will try to ping you tomorrow. If not, we will do something on Monday.
Thank you very much. Have a nice weekend.
Have a nice rest of the day.
All is well. Thank you.